is your question? Right, so if you have read and understood, considering this critical care scenario, kindly tell me how would you manage this patient?
Yes, the patient has a deranged vital, so I'm going to treat him according to CRISP protocol.
Yes.
I'm going to assess the A, B, C, D, E of patient and address them accordingly.
Okay. What would be your first line of action?
Yes, because the patient is tachypneic, I'm going to assess the airway and breathing.
Yes.
And if the patient can talk, it means the airway is clear. Second
Yes.
step will be assessing the chest for movements as well as breath sounds. And that will decide further management of this patient.
Okay. After reading the stem, what are the differentials that you'll consider?
As the patient has undergone a CVP procedure
Yes.
recently, it could be possible that he may have a hemothorax or pneumothorax.
Okay. What are the types of pneumothorax that you know of?
There are two different classifications. One is primary and secondary, depending upon pathology. The other is simple pneumothorax, tension pneumothorax, or open pneumothorax.
Okay. All right. How would you know what are the signs of pneumothorax that you'll know, and then you can diagnose it?
Yes, there will be hyperresonant chest. There will be decreased chest expansion, and there will be decreased breath sounds on the affected side of pneumothorax. And the patient will be using accessory respiratory muscles, and he will be in respiratory distress.
Okay. Can you tell me how would you differentiate between simple pneumothorax and tension pneumothorax?
Simple pneumothorax, usually patients are vitally stable. In tension pneumothorax, they deteriorate very rapidly, and there are obvious signs of respiratory distress with increasing respiratory rate, and there could be signs of shock as well because of the compensation of circulation that happens due to tension pneumothorax and reduced venous return.
There is actually mediastinal shift in compression, that's why. All right, okay, can you please tell me, if you have to manage a patient with pneumothorax, how would the management differ if the patient has simple pneumothorax as compared to tension pneumothorax? Basically, tell me the difference in management. Yes.
If the patient has tension pneumothorax, we need to treat it immediately without offering any investigations. We need to puncture the second intercostal space, and this will release the tension pneumothorax with a hissing sound.
Is that all you'll do? So how is it different once you have to manage simple pneumothorax? Because this is what you'll do for
in the emergency,
yes.
immediate. Yes, the patient will require passing a tube tracheostomy after he is stabilized. And if the patient has pneumothorax, which is simple pneumothorax, then we can assess the situation according to the X-ray findings and patient's clinical findings. If there is a space, if there is a space of more than 2 centimeters, if there is a space of more than 2 centimeters and patient has obvious signs of pain and respiratory distress, then we are going to pass a tube tracheostomy.
Okay. Can you mention few indications of central line insertion?
Yes, it's for the management of heart failure, especially measuring the right atrium as well as pulmonary capillary wedge pressure. If any chemotherapy or hyperosmolar substance needs to be given, it can be passed through the central line as well.
And
So main function
case
is
of-
monitoring the patient.
yes.
Yes.
And
In case of TPN or
TPN,
chemotherapy.
or for hemodialysis as well. Okay. Can you
Yes.
name few complications that can arise as a result of a central venous line insertion?
Yes, central venous line insertion can lead to bleeding if
Immediately, yes.
if artery is punctured or if the vein is punctured through and through. Apart from that, it can lead to cardiac perforation or tamponade and pneumothorax as well as pneumothorax.
Right. It can also lead to sepsis or infection on thrombosis.
Yes, air embolism as well.
All right.
Yes.
All right. So okay.
Late complications.
Yes, these are the late ones. All right. If you are asked to insert the central line according to NICE guidelines, how would you do it?
Yes, the recent guidelines involve passing the CVP line in theater under ultrasound guidance, and this will involve the patient identifying the landmarks that include the triangle that is found by the medial and clavicular head of that is the sternal and clavicular head of sternocleidomastoid. At the apex of this triangle, we are going to identify the carotid artery, and just lateral to it lies the internal jugular vein. And we are going to use the guide wire technique, that is the cell digger technique, to insert the CVP line.
And
under
anything
the
else that you have
ultrasound
missed?
guidance.
Ultrasound guidance.
We need to strict aseptic measures should be used.
Yes.
And
how would be the position of the patient?
Position will be internal position, that is head down.
Yes.
Yes.
And what is the most important?
What
is the most important thing that you will do according to the NICE guidelines? After you have inserted, you will do the
we need to check a
procedure radiograph.
Yes, X-ray.
Yes, that is the important one. Okay, can you please tell me the surface marking of internal jugular vein?
Yeah, it starts from the ear lobule and ends at the sternoclavicular joint. A straight line that starts from the ear lobule.
Yes, and between the two heads of okay. Right, you told me this. All right, what is the technique for the removal of central line which should be followed?
The central line should be removed under strict aseptic measures, and the patient should be. I'm sorry, ma'am. I'm not sure about that question.
You're telling me, okay, aseptic, and then head down to prevent air embolism. Okay, this is the most important you have to consider. Okay, can you tell me what are the indications when you say, okay, now we should remove the central line?
Yes, when the patient, yes, if there is temporary placement of CVP due to for hemodialysis, then once the AV fistula is made, then it can be removed. Or when the patient is vitally stable and the indication is no longer present, there is no point in keeping the CVP line for a long period unnecessary. Once the indication is over, it should be removed.
If it is foci for sepsis,
yes, infection as well.
Okay, yes. Can you please tell me what is the most common cause of infection? Which organism?
The most common organism? Yes, it's Staph epidermidis and Staph aureus. These are the most common infection causing organism.
Okay, and if we can tell me what measures can you take to prevent the infection of CVP?
Yes, usually it's the strict aseptic measures practiced by the staff that should be trained, and the line should not be used unnecessarily for those drugs that can be administered through a peripheral cannula.
Yes.
And it needs to be heparinized every 4 or 5 hours.
If you suspect,
it should be.
Yes. if you suspect pneumothorax, what
If
is the immediate investigations that you'll ask for?
we will ask for a chest X-ray as well as an ABGs of the patient.
All right, good. Okay, sometimes, all right. Sometimes once you're inserting the central line, you have to find out the higher point. So what can be the higher point or highest point of inserting into internal jugular vein?
Yeah, that's the landmarks, the triangle found by the sternocleidomastoid two heads. The apex of this triangle should be the highest point that we can insert into the internal jugular vein.
Okay.
Apart from that, it can be inserted in subclavian and femoral as well.
Yes.
But that will be PICC line, that is peripheral insert, it's central catheter.
Right. Okay. I think I have asked you almost everything. Yeah. So my little feedback that once I asked you about the complications, then you told me you begin very well with the bleeding, but then you can maybe divide them into acute or early and late complications. Yeah. Yes.
Yeah.
Good.
Yeah.
Good.
Yes.
Can you please help me read this?
Yeah. This is X-ray of the patient. Epi view. I can clearly see there is collapse of the lung on the right side. Yes. And there is mediastinal shift, and there is enlargement of heart shadow as well. And trachea shifted to the left as well. And it's a case of tension pneumothorax.
Yes. Okay, so before we were reading X-rays, so there is one mnemonic that they say A, B, C, D, and then G, H, and then T as well. So they say A for the airway. You can see if the trachea is central or not, or it's deviated to whatever side, and then you can see the bones. If there are any associated bones, fractures or injuries or anything, then C for the cardiac shadows and everything, and the D for the diaphragm. Can you see the diaphragm? Is there anything visible?
Yes, it's very slow down.
Yes, and then E and F.
I think there is on the right side. There is.
Yes.
On the right side there is diaphragm rupture with the gastric shadow moving upwards.
Moving upwards. So that's what I was telling you. So you have to look at that as well. And then you have to look at the equal lung fields. So they are not equal, so that you can see.
Yes,
and then there is also gastric bubble, which has disappeared. It's not there because stomach has been moved up. And then the there is hilum and mediastinum. Can you see any hilum and mediastinum in any of these? No, absent.
No, ma'am. Because of the lung collapse, it has been shifted.
Yes.
The whole lung is not visible.
And the last P, they say if there are any technical errors, which are human created. So that's how you read quickly, but then keeping all these points in your mind. Then you can tell or comment.
Yes, ma'am.
Good. Thank you.
Thank you, ma'am.
Thank you.